Is it ready? Good morning. Thank you for coming, and we are so happy to welcome Longstreet Clinic and Mary Reed, MD, who is a breast and general surgeon with Longstreet Clinic, and we have Maggie, and I'm sorry, you're Christy, and we're so glad to have them from Longstreet Clinic. Mary Reed, our physician, was a graduate of LaGrange College, and I was questioning her that she grew up in the Marietta area, and she's married a Georgia native, and they live here in Gainesville. But Mary received her MD from the Mercer University School of Medicine. My father was a Mercer University graduate, so I'm familiar. She did her residency at the University of Tennessee School of Medicine, and she is board certified. So we are so pleased to welcome her this morning. Thank you.
All right, I'm live, so you can hear me okay. It's very nice to meet all of you. Thank you all for attending this morning on this very important topic of breast surgery, particularly breast cancer. One thing I wanted to mention is that they did mention that I did train at University of Tennessee, so I do wear orange on Saturdays in the fall. So please don't count that against me, but we have a wonderful team at Longstreet Clinic. So myself, I'm one of the new breast surgeons here. Christy Graybill is our nurse practitioner who runs our high-risk clinic as well as some surveillance and survivorship clinic. And then the other surgeon who is apologetic, he could not be here today, Dr. Gary Bush, is also one of my colleagues and is a breast surgeon as well. You guys may have remembered the pillar of our community, Dr. Strom. She retired last December, and she has just been a wonderful mentor teacher to me. And so that was the idea, was to bring me in to fill her shoes. Quite a big shoe to fill, but I'm up for the task. So. Thank you all for coming today. I'm going to talk a little bit about breast cancer in general, and then we're going to go into some of the advances of breast cancer treatment, and then lastly, I'll be able to answer any questions that you may have. So first off, breast cancer is the most common cancer diagnosed in women. 1 in 8 women in their lifetime will be diagnosed with breast cancer. That's terrifying. Over 300,000 women were diagnosed with breast cancer in 2024 alone. The good news is that since 1989, over 500,000 cases that would have progressed on to die from their breast cancer did not. And that's just a testament to the advances in treatment that we have. And so ultimately, we do know, we'll go into a little bit about screening, but screening is the number one thing. We'll talk a little bit about things that you can do to prevent breast cancer, but let me go into a little bit about the advances of breast cancer. So historically, we used to know, patients would present with a lump in their breast. They would be seen by a doctor. They would get imaging at that point, and then ultimately, they would go on to treatment. And treatment could consist of surgery, being the historical Halsted mastectomy or modified radical mastectomy, or radical mastectomy, where they would actually take your muscle of your chest wall, take all of the lymph nodes underneath your armpit, just a lot of surgery to undergo for this disease. Additionally, patients used to get lots and lots of chemotherapy that would have several different toxicities involved with it. And so thankfully, through research, through funding like the Susan G. Komen for the Cure research and all different kinds of cancer research, we know that breast cancer doesn't need a sledgehammer. It needs a very tailored approach. And so ultimately, when you get diagnosed for breast cancer, nowadays it's usually very, very small. And then one of the most important things about that breast cancer is the information about it, meaning the tumor biology. And so we're really able to nowadays target specifically tumor biology as the means to which, because we know as each individual of us is much different. I have red hair, Christy has brown hair, Maggie has brownish blonde hair. We know that each individual breast cancer is tailored towards the patient. And so there are patient factors that we have to consider, age, fertility status, all those things. And then ultimately what the tumor biology is. And we're really able to patent down what kind of treatments are involved in that. And so really able to tailor that treatment towards you. Additionally, the one wonderful thing about being at the Longstreet Clinic is we have access to the Longstreet hematologist oncologist and the hospital radiation oncologist as well as their hematologist oncologist. And we all get together and go through each individual case of breast cancer called a tumor board. And tumor boards are so very important because we get the opportunity to get all the minds of breast cancer together to chat about your each individual breast cancer. And if we have questions or debate, sometimes it can get a little spicy in those tumor boards. We don't mind. It's all in the best effort. But so ultimately, that is the biggest thing. So what can you do to help prevent breast cancer? Unfortunately, breast cancer is not like lung cancer, where if you just avoid smoking, chances are you probably won't develop breast or lung cancer in your lifetime. Or any number of things that you could do to prevent other cancers. Wear sunscreen for skin cancer, of course. Breast cancer is a little more nefarious than that. And so things that you can do on a regular basis: eat healthy, exercise. We know that those things contribute to living a healthy lifestyle, can help prevent it. Avoidance of smoking is always good and also has been shown to prevent breast cancer. We always talk about things like breastfeeding, avoiding avoiding hormone replacement therapy, all those things. But we know that we're trying to improve your lifestyle. We're not trying to take away your lifestyle. Quality over quantity for many, many patients. But ultimately, screening is the key. So here I am. What month is it, May? Here I'm in May talking about breast cancer screening. I wore my little pink ribbon here. But you should be wearing pink all throughout the year, because at any point in the year, you should be getting screened for breast cancer. So screening starts at age 40, and then annually following that. There are some societies that recommend you can go to biannual at 55. I, as a breast surgeon, recommend continuing annual screening up until about 10 years from your life expectancy. But we know age is just a number. So I tell patients, if you're willing to do something about the cancer, get screened. Okay? So ultimately, I wanted today to be a little bit of conversation back and forth. If you have a story you'd like to tell, or if you have questions specifically about breast cancer, I can go on and on and on and talk about breast cancer ad nauseum. And so I invite you to ask any questions you may have. And make sure you raise your hand so that they can.
I came in a little late, so you might have touched on this. What does Medicare pay for screening in our age group?
Yes.
And are there any exceptions, such as a history of breast cancer or other cancers?
Good question. So Medicare, Medicaid will pay for an annual screening mammogram. And then there are things like Christy is part of our high-risk clinic. So if you have dense breasts, or if you have a strong family history of breast cancer, then we can get some other modalities brought in for you. If you also have a personal history of cancer, options such as ABIS, which is a whole breast ultrasound, which tends to pick up smaller lesions that are undetectable by mammogram. And then secondly, MRI, which we know breast MRI is the best screening tool for breast cancer, but it's expensive and can be timely for you as the patient. And so we at the clinic can kind of tailor your screening to you, but in general, annual mammogram.
I'm new to the area and been having 3D mammograms. So you didn't mention 3D. So I was curious about
So
that.
there are a couple of different mammograms that are available, but number one, just annual screening mammogram, which is designed to pick up on any lesions. If they do pick up on something on screening mammogram, then you'll get that scary phone call back to come get diagnostic mammograms, which could include a 3D mammogram or could include a contrast enhanced mammogram. And so those are some other ways that you can get screened in a diagnostic manner as well if they see something abnormal, absolutely.
Would you address male breast cancer? I had a
Absolutely.
dear friend that passed away
Yes.
from metastatized breast cancer.
Absolutely. And so ultimately, we do know breast cancer is a disease of mostly women, but it oftentimes does happen to men too. So we know that about 2,500 cases of male breast cancer occur. And typically, when males present with breast cancer, it's at a more advanced stage. And so even if you're a man, knowing your body, paying attention to your body, we don't have any guidelines for screening in the male population, save for anybody that has a hereditary genetic mutation for breast cancer. We also know that male breast cancer tends to have a high correlation with a genetic predisposition. So women, knowing your history, if you have a man in your family that has had breast cancer, knowing that that could, perk your ears to knowing that you need to be tested for any sort of genetic predisposition. Addition, men, I cannot emphasize this enough, know your body. Make sure that if you experience any lumps or bumps, you should be talking to your doctor and getting those checked out.
Do you guys do genetic testing?
We absolutely do genetic testing, yes. So if you get diagnosed with breast cancer or you have a strong family history of breast cancer, then I will, that is part of my algorithm and part of the NCCN guidelines is to offer genetic testing. So it's not just genetic testing for breast cancer either. We do a whole panel of genetic testing which could explain increased risk of pancreas cancer or any different kind, brain cancer, any different kinds of cancer, and so that's available to you as well.
Would you talk to the relation of breast cancer to estrogen?
Absolutely. So we do know that most breast cancers are hormone receptor positive, meaning the breast cancer cells expressed estrogen and progesterone receptors, which is the driver of the growth of those tumors. And so we ultimately know that over your lifetime, a totality of estrogen exposure increases your risk potentially of breast cancer. Meaning we know that breastfeeding is protective because that decreases the amount of estrogen exposure. We know that taking hormone replacement therapy could increase your risk because it increases the amount of estrogen in your lifetime. And so early set of menses, late set of menopause, all those things contribute. And so ultimately, a lot of those things are out of your hands. Breastfeeding is a little bit in your hands, and then hormone replacement therapy, certainly, like I said before, we want to make sure we're quality of life sometimes over quantity of life. So I counsel my patients that are on hormone replacement therapy. I'm not trying to make your life miserable in order to decrease your cancer risk. It's very possible that you take hormone replacement therapy and never develop breast cancer over your lifetime. It's also possible that you take a month of it and develop breast cancer. So ultimately, we just know that as minimal as possible and as topical as possible in terms of that. But yes, estrogen exposure itself can increase your risk in terms of the length of estrogen exposure.
If you've taken hormone replacement in the past and have not for a number of years, does the effect gradually diminish?
We don't know exactly the answer to that, but if you take it for a period of time and stop taking it, we know that in general your breast cancer risk is higher than average, but we don't know to what degree and whether or not that will contribute to development of breast cancer in the future.
What's the current data on topical estrogen increasing risk of breast cancer?
Good question. So as long as it's not systemically absorbed, then we think that it does a very, very low risk for increasing rate of breast cancer. So when we talk about topical, we know that sometimes there are some creams that you can put on your arm or that are actually absorbed systemically that help with systemic symptoms. But vaginal creams, things like that, we think of not increasing your risk very much. Did that answer your question? Okay. And like I said, nobody's trying to make anybody's life miserable to decrease their breast cancer risk. The biggest thing you can do is get screened, because even if you take hormone replacement therapy, like I said, you may never develop breast cancer of your lifetime. And if you haven't taken hormone replacement therapy, you could develop breast cancer of your lifetime. So, like I said, quality is paramount, I think, in terms of quality of life is paramount when having that conversation.
Yes. Could you talk about the estrogen suppressing medication that you take after you have had breast surgery?
Yes. So, in terms of breast cancer care, typically there follows 3 different treatment parts, depending on the type of treatment that you choose. And I'll touch on that and just go as we go into it. But number 1, surgery is usually a part of that, meaning I can either perform a partial mastectomy, meaning local resection of the tumor with a healthy rim of tissue, or we can do a mastectomy with or without reconstruction. We talk about lymph node surgery. There's a conversation of chemotherapy and then radiation therapy plus or minus depending on the type of surgery and the details of the pathology after surgery. But particularly for hormone receptor positive tumors, we know that blocking those estrogen receptors, we're not blocking the creation of estrogen. Your body, even after menopause, has a low level of estrogen around it. Our adrenal glands make the precursor to estrogen. That gets converted to our fat cells into estrogen in our fat cells. And then with or without your ovaries, you make a low level of estrogen with those as well. And so our idea is that at the level of the breast, we are stopping the breast cells, the normal breast cells, from seeing that estrogen. So potentially stopping that growth of any new tumors. And so that's the justification behind taking a hormone receptor blocker. We do that post treatment to hopefully reduce the risk of recurrence of it ever coming back. And so many women tolerate the side effects of those well. It depends on which type of medication you get, premenopausal or postmenopausal. But like I said, most women tolerate it pretty well. There are some side effects that are sadly like menopause. So hot flashes, arthralgias, things like that are generally well tolerated. But it's a conversation with your medical oncologist as to whether you continue that post treatment or not. I think I saw another hand somewhere.
I moved just this past year here, and I have a notice to get a mammogram.
Mm-hmm.
It's time. So I'd like to do it here. Is it just call the main Longstreet number? Or
Absolutely. So
transfer.
Okay, good. So in the cup we gave you, there should be a card that you can just call Longstreet and get your mammogram scheduled. Absolutely. Yes, yes.
I have a question that's not really about breast cancer, but it's in the paper and news that you will be absorbed by Northeast Georgia Health System by the end of the year. Is that going well with Longstreet Clinic?
Yeah, we are very excited. I think the union of these 2 institutions is a natural and healthy thing for our health system in Gainesville. And I think it's only going to boost each other. The idea is that with the support of the hospital, it just increases the amount of resources in both directions. And so we're very much looking forward to joining with the hospital. But we will still be in the same building. We will still be the Longstreet Surgery Department. So we're not going away. We're just maybe at some point changing a color or 2.
More questions? Well, thank you so much.
Thank you.
I appreciate you taking your time and impending a birth, and this is her second child,
Yes.
so she's a busy person.
Yes, and I wanted to reiterate, if you guys have any questions, if you notice anything or have any needs, just call our office. We're happy to see you, get you scheduled for any questions that you may have, and we're a resource to you guys. So,
Thank you.
Thank you.
Thank you for coming.
yeah.